To be honest with you, I sort of wanted to be a doctor from the time I was about 5 years age. And I was always interested in the heartbeat. I remember trying to find out in the World Book Encyclopedia where the electrical impulse goes after it activates the heart. And of course, that was at a very early time, in the early 50s. Because of my mother, who was the director of the operating rooms at Downstate Medical Center in Brooklyn, large institution, I was always able during the summers when I was in high school and college to work with one of the cardiac surgeons there. And I remember them putting in pacemakers. When I got to do my residency, and I did that at Texas Children's Hospital because that's where I wanted to do my fellowship, my first mentor was Tim Garson. He was my supervisor during residencies. I had made it clear to the department that when I got my residency there that I wanted to do my fellowship there, and my interest was in electrophysiology. So they asked him to be my advisor. We wanted to put together an organization that we thought would be somewhere for us to live within the confines of NASB, or the Heart Rhythm Society, but that carved out a place of our own as an advocacy group for children with those problems. And I think it caught on. Obviously, there was a growing need for clinical electrophysiologists in the 80s and 90s, early 90s. And so there was a natural growth in the membership that was interested in that area. I think the thing that turned the corner in terms of Heart Rhythm Society really embracing the pediatric community was the growth of adult congenital heart disease. And I was fortunate enough to be working with Paul Gillette, who was my ultimate mentor, and Tim Garson during that time. When I was a third-year fellow, we had a 20-something-year-old Downs patient who had an infected pacemaker. They took him to the operating room and opened up his pocket and tried to pull on the lead, and it didn't do anything. The way to extract the lead was to exteriorize it, put a 1-0 suture around the lead, put it over a pulley, tie it to a Coke bottle, and add sand every day to it. And that's what they were doing. And I happened to be on service when this was going on, and it was just absolutely bizarre. And I was standing next to the patient on about the third or fourth day, and all of a sudden, the lead comes flying out with a hunk of muscle on it from the right ventricle. Everybody sort of jumped. He had enough scar tissue around the heart that he didn't end up with a hemopericardium, but it was right then that I decided there's got to be a better way. We tried to do a lead extraction with the very early equipment with a patient not under general anesthesia. That did not go well. I was not an attending at that point in time. I was a senior fellow in electrophysiology, but I then went and learned from Charlie Bird how to do this. I remember when we were doing this with the telescoping sheaths, which were polypropylene, that he said, and he was a cardiac surgeon, so of course he could feel comfortable cracking a chest if anything happened. He said, this rarely happens, but you can actually tear the heart. And he did. I gained an appreciation about the complexity and the cautionary kind of process that you needed to go through to make sure that patients actually survived this if the worst happened. It's much more developed than it was at the beginning. I think at the beginning it was sort of a fellowship of pediatric electrophysiologists that wanted to learn from each other, understand how we could collaborate and answer questions. The first big thing that I felt I gave to PACES, or our organization, was putting together the radio frequency ablation symposium that we had that ultimately resulted in publication about the experience and recommendations for that. And that was very well attended. There was a lot of involvement. I think it was at the time when we were finally able to treat the stuff that we were finding. So when I was an electrophysiology fellow, basically in Texas, what we would do is map out where the thing was, take the patient to the operating room, put either a band around the AV annulus to try and put the patient in tachycardia and map it out there, similar to what we did in the operating room, in the cath lab, and tell the surgeon where to cut. So it was a very frustrating experience of spending hours and hours of doing EP studies. And of course, at that time, we didn't have digital recordings of the thing. And so we had it on paper that was in rolls. And the job of the EP fellow was to make all the measurements on that. And depending upon who your attending was, you were either there all night. Thank you, Jeff Moak. But you learned a lot. And so that was really the change in what electrophysiologists could do. It took electrophysiologists from the diagnostic part of medicine only to the actual curative, therapeutic part of it. And it was, there was an explosion of people wanting to go into that area. It wasn't just an intellectual exercise anymore. It was people that wanted to not only be able to understand what the EP study was all about, but then go ahead and cure the patient. And that's a very powerful stimulus for people to do. And so there was this growing need to take this community of expanding electrophysiologists who were pediatric cardiologists and make sure they were together and advocating. And so the radiofrequency ablation consensus conference was a big part of that. The future is difficult to say. I think that increasingly, because the adult congenital population now is bigger than the pediatric population with congenital heart disease, and one of the major complications is the need for defibrillators, the need for EP studies. We will be working with the adult electrophysiologists in tandem. But I think that the future will be working hand in hand with the adult community as they become more interventional in nature. I also think that we have a unique opportunity going forward as pediatric electrophysiologists to take patient data, similar to what we did in the PAPCA registry, but now actually do it in a much more facile way in terms of taking that digital data, incorporating it into a database, and using it as a more powerful tool than we had before. I look forward to doing that. I'm interested in the informatics area, and I think that's the future of medicine, and I think electrophysiology will move in that direction as well. Ask questions. Try and answer them. Try and understand that the academic advancement should be something that's secondary to your questioning. And don't be afraid to try something new, as long as you know what you're doing with it and have carefully experienced all of the potential problems. But always remember that when everything is said and done, and as I reach the twilight parts of my career now, the only thing that people will remember about you 10 or 15 years after you're gone is not the papers that you wrote. It's the patients you treated and the people you trained. Those will be your legacy. And if you're looking to have a legacy, that's what it is. And so embrace teaching. Take time with it. Make sure that the people that train under you are taken care of in terms of getting them interested in answering questions that they may not know the answer to now.